അപ്പോൾ ഈ ഒരു വെബിനാർ സീരീസിലേക്ക് വൈറൽ ഹെപ്പറ്റൈറ്റിസിലെ ക്ലാസ് എടുക്കാനായിട്ട് വർക്കല ജില്ലാ ഹോസ്പിറ്റലിന്റെ പേരിലും ആറ്റിങ്ങൽ AMI ഏരിയ കമ്മിറ്റിയുടെ പേരിലും ഡോക്ടറെ സ്വാഗതം ചെയ്യാണ്. ഡോക്ടർ റെഡി അല്ലേ?
അതെ.
ഡോക്ടറെ ഹാർട്ടി വെൽക്കം. തുടങ്ങിക്കോളൂ.
Thank you. So today WHO has regarded July 28th as the World Hepatitis Day. So thank you AMAI and government Ayurveda Hospital VARKALA for giving me a small space to just briefly go through the theoretical parts of viral hepatitis. Hepatitis basically means the inflammation of liver. So it can be caused by various causes. And when we go through the infective part, it's mainly caused by many viruses. So all the hepatitis caused by viruses are called viral hepatitis. There are many types of viruses causing hepatitis. So mainly we are today dealing with the hepatitis A to E viruses. Apart from this, many other viruses also cause hepatitis like IMN, cytomegalovirus, Epstein-Barr virus, etc. So mainly today we will deal with the hepatitis A to E. So we know that the burden of hepatitis, especially B, is very much high in our world now. Around 400 billion people are infected with hepatitis B now. So basically the main problem is the infective load and the complications caused by this disease. So we will start with first hepatitis A. So going to hepatitis A, we will start an introduction with the virus. Usually A to E, majority of the viruses comes in RNA virus category, and only one, hepatitis B, is DNA virus. So starting from hepatitis A is an RNA virus. It comes, hepatitis A virus is an RNA virus, comes under the hepatovirus. It comes under genus of hepatovirus, which comes under Picorna viridae family. About the viral activity, practically we can tell that this boiling of this virus for 1 minute, it can reduce the viral activity. And mainly 4 genotypes are found out of hepatitis A, which are 4 of them are immunologically indistinguishable. So we broadly term it as a one serotype. So once we all know that the mode of transmission is mainly fecal-oral route. So once the virus enters our body, the incubation period is nearly 4 weeks. So 4 weeks, mainly this virus enters our body and it replicates in the liver. And mainly the portion affecting is liver. Sometimes the virus is also seen in bile, blood, stools, etc. Next, please. Okay. After infection occurs, there is an acute phase of infection. So we are concerned about the antibody produced in the body. So the antibody in the acute phase produced is IgM. We all know that acute phase antibody is IgM, and it lasts for nearly 3 months in the body, and sometimes around 6 to 12 months it will be present in the serum, but usually within 3 months, up to 3 months, the antibody will be present. And all know that hepatitis A disease itself is a self-limiting infection. Within 6 months, majority within 2 months, it will be resolved from the body. So IgM antibody can last around nearly 3 months. And in the convalescence, after the infection, this IgM antibody disappears and IgG antibody appears. IgG, we all know that it is a chronic antibody, and this IgG will persist in the body for lifelong. And this is the antibody that giving immunity to us. And sometimes only around 1%, the acute infective stage, 1% of the patient cause to a serious condition called FHF or fulminant hepatitis or fulminant hepatic failure. Sometimes there will be some variations in the genotype. Maybe because of that, studies അങ്ങനെ പറയുന്നു ചില variations കൊണ്ട് ആ virus may become more dangerous to the body, and also in some particular age groups, it can go to pulmonary hepatic failure means the patient is in a very bad condition. Extensive liver necrosis, hepatic coma, all രീതിയിലേക്ക് പോകും. So apart from that, we will go for the epidemiology. Epidemiology, we all know that the transmission, it's a fecal-oral route, mainly how the infection occurs due to poor hygiene, poor sanitation. We all know around about the third world countries and all, where the sanitary conditions are less, open defecation. All this causes contamination of food, drinking water, could be milk products, vegetables. Anyway, this fecal-oral route is the main mode of transmission of the virus. And also, if a person is infected, there is also a risk. There is their close contacts, like in intra-family, those who are supposed to be interact with the patient very close. It can also be a risk. So there is the question of immunization coming in. So intra-family close contacts, etc. Sometimes they can also be susceptible to infection. And as we all know, it's a also nowadays travel is very common. So somebody traveling to endemic areas where hepatitis A is very much prevalent, they are also prone to infection. And also in Western countries and all newly recognized childcare centers where children interact very closely, it can also be a cause for the disease. And very rarely, even if it is fecal-oral route, very rarely some cases are reported with IV PWID means PIWD persons who inject drugs, IV drug users. Sometimes through transfusion also it has been seen. Also MSM, like male sex homosexuals. Also,
Yes.
hello?
sir.
Hello? Okay.
Hello.
Okay. Okay, some studies in US have conducted that in some high prevalence areas or high incidence areas, they have implemented vaccination strategies where in some states in US, the cases load ഒരുപാട് കൂടുതലുള്ള high incidence areas, they implemented vaccination. And vaccination their effectiveness. After the implementation of vaccination, the annual case rate have declined by 70%. So that is the effectiveness of vaccination. So coming to pathogenesis. About the pathogenesis of HIV. This virus is ingested, and once it gets into the body, after it survives the gastric acid, and it is, where will it go? It will go to the intestine. And from the portal circulation, it can go to the liver. So it reaches the liver, it infects the hepatocytes. There, in the liver, it replicates, assembles, and through the bile canaliculi, it again reaches the bile duct. The bile duct again reaches to the bile duct again reaches to the intestine, and from the intestine, this virus is again shed through the feces. So this is the pathological cycle. So during the incubation period, 2 weeks, and after the onset of disease, this person's species will be infected. So coming to the clinical features, we all know that the hepatitis A is a self-limiting infection. So there is no chronic infection. It is only a acute self-limited episode. So incubation period is usually 2 to 4 weeks. That is for 15 to 45 days, nearly 6 weeks. Nearly 6 weeks. So clinical features, mainly the most common is around 68 to 68.1% of patients shows jaundice. Jaundice is the main symptom, and sometimes in older adults, mainly the younger adults or with good immunity, they don't need much treatment, only supportive care. Sometimes in older adults with who have some comorbidities or with reduced regenerative capacity of the liver, or those who have less immune function. Second, with hepatocellular dysfunction, sometimes this person may need medical attention and hospitalization. So there is some degree of mortality among those patients. Okay. And coming to the phases, next please. Next. There are several types of presentations in the hepatitis B infection. Usually, these are the phases seen in some age groups, and also some rare type of presentations are also seen. First is only anictric hepatitis. Anictric means without icterus, without jaundice. So rare, usually seen in children below 2 years of age. And in 20% only there will be jaundice. But most of the children infected who are of age group more than 5 years, 80% will have jaundice. That is a rare percentage of anictric hepatitis. Second, when you see the most common pattern is icteric hepatitis, and there will be jaundice. And in this self-limited infection, there will be jaundice, and it will be resolved within around 8 weeks. And next is a rare variety is called a cholestatic pattern. Cholestatic pattern because this jaundice, once it occurs in the acute phase, maybe sometime it will persist for several months. And even the IgM antibody will be positive for this much time. Very rarely occurs this long pattern. When clinician is treating this patient, this there will be jaundice, IgM will be positive, and they will be somewhat confused. They will be forced to do some other investigations also. But this is a rare type. And also there is a relapsing type. Relapsing means again within 6 months, once the infection occurs, sometimes within 6 months, again another relapse occurs. Again a jaundice occurs. Only in 10 to 15%. And within 6 months, this is resolved. And next is the fulminant hepatic failure that we have discussed earlier. A serious condition. Sometimes only 1% of the patient, they can go into mortality. Next, coming to the signs and symptoms. Before the onset of disease, there will be prodromal symptoms like weakness, fatigue, anorexia, nausea, vomiting, and also fever, malaise, jaundice, and also abdominal pain, vomiting, sometimes diarrhea. And most of the patients present with dark urine, 90% of the patient. Before the icterus phase, there will be dark urine, and once the jaundice starts, it will be resolved. And on examination, patient will be having abdominal pain, right upper quadrant tenderness, hepatomegaly. 80% of the patient may have hepatomegaly and the right upper quadrant pain, tenderness. Sometimes 50% may show splenomegaly, sometimes cervical lymphadenopathy. And we can see that almost 100% of the patients recover within six months. Maybe more than 60% resolved within 2 months. That is a clinical course regarding the hepatitis A. And coming to the differential diagnosis. Diagnosis is very easy. We can do by serology, but sometimes autoimmune hepatitis or other hepatic virus infections like B or C can be coming under differential diagnosis. And fulminant, talking something about fulminant hepatitis, we have seen that it is rare in adolescents and children. Mortality rate is more associated with elder patients. So in studies, it have shown that the patients with low immunity, less capacity of the body to contain the virus. In the study shown that the persons having certain criteria are showing more mortality in fulminant hepatitis. Mainly 3 criteria are shown, like creatinine more than 2 milligram, bilirubin more than 9.6, and blood albumin below 2.5, etc. So detail on data. Next is extrahepatic. Next. there are some extra hepatic manifestations of many HIV, HBV, HCV, all shows this extra hepatic manifestation. Comparatively rare in HIV. The mainly immune complex mediated. We know that there is antigen antibody reactions. They will attract C3 complement. It will deposit in many blood vessels, glomerulus, synovial membrane. So it can show some extra hepatic manifestations like evanescent rash with the which in the skin. It occurs within resolves within 24 hours. Then arthralgia affecting the joints, vasculitis, glomerulonephritis, arthritis, sometimes cryoglobulinemia, toxic epidermonecrolysis, myocarditis, transverse myelitis, autoimmune hepatitis. These are the extrahepatic manifestations rarely occurring. So coming to the lab diagnosis, mainly the main marker is the antibody, that's IgM. Usually IgM sometime later IgG also will be present in the serum. Both of it will be in the serum, but mainly IgM will be in the acute phase. IgM will be more than IgG. Sometimes RF factor if present can cause false positives. And the liver enzymes, ALT mainly will be high, 400 to 4,000 or more than that. These are regarding the lab diagnosis. And treatment, no specific drug therapy is seen in hepatitis C. Only just what's called supportive management, fluid restoration. Only problem is if patient goes to hepatic failure, that we have to do the liver failure or hepatic encephalopathy or hepatic failure this treatment. But normally the infection is contained. Patient needs only supportive measures. Coming to the prevention, we know improve the sanitary conditions, personal hygiene. That comes within the medical prophylaxis is vaccination. So the vaccine is available for hepatitis A. Mainly two brands are seen in Havrix and Varta. Doses usually within 18 years 0.5 ml, more than 8 years 1 ml, and the schedule is 0, 6, and 12. Means 0 day, after 6 months, after 12 months. 3 doses will give complete immunity. 2 types of vaccines are there. Nowadays, I'm not sure it's present in India. Combined hepatitis A, hepatitis B vaccine, Twinrix is also available nowadays. It gives immunity to both, mainly if going to endemic areas. If going to endemic area, there are accelerated doses also that we can take before 2 weeks going to the endemic areas. It will produce fast immunity. Okay, this is related to hepatitis A. Now we can next please. Next, this is serology pattern. First, fecal HIV. Nowadays, fecal HIV is not done. Diagnosis occurs usually depends on IgM HIV, and this total IgG HIV will be persistent throughout the life, and it gives the lifelong immunity. That's the point. And, prevention. Okay, next please. Next. Okay, coming to hepatitis B. Hepatitis B is the DNA virus in this category, and it is the Hepatidinavidae family. And basically talking about the virus, this hepatitis virus has 4 viral genes. We can remember it as S, C, X, and P. S for surface gene, which codes for the surface protein, and C is the core protein and core gene. It codes for the core protein and also E antigen. And next X gene, X codes for X protein, and P gene, it's related with the DNA polymerase. 10 genotypes are identified, A to J. And coming to the transmission of the virus, we all know that mainly percutaneous exposure transfusion, injection, also mucous membrane. Mucous membrane exposure to all the body fluids, maybe blood, semen, almost every body fluids are launching the virus. So it is 100 times more infective than HIV. And also perinatal transmission, mother can transmit the virus to the child. So coming to the diagnosis of hepatitis B, mainly it is the first antigen. Yes. Previous slide, please. Back. Okay. Okay, next. HPSAG. HPSAG is the main surface antigen. It is detected 2 to 10 weeks after exposure. So we all know that 90%, about 90% of the HPV infection itself is a self-limited infection. So the HPSAG appears in the body and it's detectable after 4 to 6 months. And if up to 4 to 6 months, it will persist in the body. If HPSAG antigen is persisting more than 6 months, we should doubt that this infection is going to a chronic pattern. So next is the anti-HPS. Anti-HPS means antibody to the HPSAG antigen. So after the HPSAG is disappearing from the serum, after some weeks, the anti-HPS will appear in the serum. And this anti-HPS will persist for the life. There is a period between the disappearance of HPSAG and the appearance of anti-HBS. This is called window period. So even if the patient is infected, if in the window period, if we test the serum, we may not be able to find the infection. Maybe transfusion related cases. Okay, next coming is the next antibody is anti-HBC. Antibody to HBC antigen, and it is mainly in the acute phase. It's IgM antibody. That is 4 to 6 months in the acute period. This anti-HBC antibody will be IgM category, and after it will change to IgG chronic antibody. Next is an important antigen called HBe antigen. HBe antigen is important in nowadays. It's clinically more important because it appears in the acute infective phase, and also it reaches the peaks along with the HPSAG antigen. But during this phase, in the appearance of HPSAG and all, HPSAG antigen, the liver enzymes will not be that high. Once the it takes a slow course. Once the ALT levels reaches in the peak, the HBeAg antigen will disappear from the body. Disappears. And also, if HBeAg antigen is going to continue more than 3 months, so we should suspect the case this patient is going to chronic infectivity. So what is the relevance of HBeAg antigen? It denotes the viral replication rate. That is, we should know that the virus is still active in the body and it is getting replicated. And next is HBV DNA. We can quantitatively analyze the HBV DNA by PCR and all. So what is the relevance of HBV DNA? HBV DNA usually comes to evaluate the patient, mainly to select the drug or select the therapy, and also to evaluate the response to the treatment. This is that shows the viral load, means if patient is responding to the treatment and all. So these are the main serological markers for in HPV infection. This slide, this is a little detailed one because nowadays these phases are being studied in the hepatitis. This is a phase of the infection. Phase 1 to 4 is mainly, fifth phase is also added. So we can start with the immune tolerant phase. That is first the infection. It usually we should think of perinatal transmission. If a newborn is infected with HBV virus or early years of life, if children getting infected. So in this phase, it is immune tolerant. That is, this HBeAg antigen will be high or positive in the body. And HBV DNA, that's virus replication, also occurs within the liver. And its count is denoted in the number 10 raised to 7. It is the cutoff in the 10 raised to 7 international unit per ml. So HBeAg will be positive, HBV DNA will be present, but there will be minimal liver affection. Liver cells adhigam problem ഉണ്ടാകത്തില്ല. Liver minimal inflammation of fibers or no microinflammation at all. But the seroത്തിൽ ഇതെല്ലാം rising. This goes for some decades. ഒരു കുട്ടിക്ക് ഇൻഫെക്ഷൻ കിട്ടിയിട്ട് കുറച്ച് 10, 20, 25 around 20 to 20, 2 or 3, maybe 2 decades വരെ ഈ ഒരു phase പോകും. So histologically there will be not much affection. So this case goes to an immune active phase. Immune activity തുടങ്ങും. As such, the virus is not directly cytopathic. It is affected. There is some immune responses in the body that causes the necrosis of liver. So immune active phase, the HBeAg antigen will be seroconverting. It will disappear and it will go to disappearance, and the anti-HBe antibody will be seen in the serum. So in this phase, the necroinflammation starts. That is, ALT level began to rise. ALT will high, but viral load, HBV DNA will be less, replication will be less, 10 raised to 4 to 10 raised to 7. It's mainly due to immune activity, cytopathic CD8 or cytotoxic lymphocyte activity. Due to that, liver inflammation occurs, necrosis, and it may lead to cirrhosis. So we should be careful about this state. One prenatally or early in the early years of life, somebody is infected, somebody is going to this HBeAg seroconversion, and the enzymes are going elevated, HBV DNA not coming down, but histologically or sonographically we are seeing the stage of liver inflammation. Maybe the patient, this is the stage where we have to take into action. Maybe treatment. In this case, antiviral treatment is important. So prevent the patient from going to chronicity. And sometimes this phase go to inactive carrier state. The seroconversion occurs. HBeAg is converted to anti-HBe. Again, after some inactive phase, some HBV replication occurs, and HBV DNA will be minimal, less than 2000, and also minimal necroinflammation. Patient is going to a silent or inactive carrier state. So sometime goes with the carrier state. After some time, there will be a reactivation in the later periods of the life when the patient is immunologically less active, his regenerative capacity is less, or some other immune suppressive drugs or some immunosuppressive condition comes. Again, the reactivation phase occurs. So the HBeAg will be negative, but HBV DNA will become high, enzymes will rise, and there will be loss of immunological control for the DNA replication. This is the next reactivation phase. Carrier state is going to reactive. And sometimes the body itself clears the virus. 90% of the patient goes to the clearance phase, limited within the body. So in HBsAg will become negative. HBeAg will become negative. HBV DNA will be undetectable, and there will be no inflammation or minimal fibrosis. So infection is controlled. These are a clinical phase of HBV infection. Next, and next please. And in case of HBV infection also, we can see some extra hepatic manifestation. Mainly the same mechanism as in HIV. We have seen arthritis, dermatitis. Sometimes if in this case, unknowingly, if you are going with steroid therapy, it can lead to chronic hepatitis B infection. polyarteritis nodosa, glomerulonephritis, sometimes cryoglobulinemia. These are all immune complex mediated syndromes. That is extrahepatic manifestation of HBV. And another important thing is about the infection in pregnancy. If I am Hep B positive mother, so what to do with the baby? If a hepatitis B mother is giving birth to a child, so in the mother, this HBV DNA, oh, sorry, HBV, not HBV DNA, HBeAg antigen, when we are assessing, if it is more than 10 raised to 7, that limit that we have seen earlier, if it is more than 10 raised to 7, that is viral replication is very high in the lady. So what our assessment is that child is at higher risk to be infected with HBsAg. So the child is more prone to become HBsAg. So what to do during the delivery perinatally? The child should be immunized with an immunoglobulin shot and routine vaccination procedure. Sometimes if the HBAg mother, the viral load is less or replication rate is HBAg is less than 10 raised to 7, we will assess the previous history. If this lady had previous children, previous delivery, if one child is infected, so assess that if the child has been properly immunized in the same pattern, even if properly immunized and the child was infected, so it is also high risk case. So we have to go for immunoglobulin and vaccination. And if the child was improperly vaccinated in the former delivery, so it could be the defect of the immunization. So it is a low risk. In that also, we have to immunize the child. So coming to the prophylaxis of Hep B vaccination. Vaccination comes in two types, active and passive. Passive means we are giving passive immunity to the patient. That is hepatitis B immunoglobulin. This immunoglobulin mainly consists of the anti-HBs. Anti-HBs is the main antibody, IgG antibody present in the body that is giving the, naturally it is giving the lifelong immunity, but we are giving it as immunoglobulin in vaccination. So who should take this? We have said about the perinatal transmission, children, also high-risk persons who may have frequent dialysis, some patients with clotting disorders, receiving clotting factors, frequently hemodialysis, and also the perinatal transmission. The immunoglobulin with routine vaccination within 24 hours. It will provide immunity for the child and also for this person. And for this, apart from the perinatal, other persons will get temporary immunity. Next is the hepatitis B vaccine. Hepatitis B vaccine is this produced by a recombinant method. That is, the S gene from the virus is incorporated in the yeast and the HBs antigen is produced. So mainly two brands are available, Recombivax and Empirix. It's given in the deltoid. So we are giving HBsAg and it will produce antibody in the body. So what is the titer of antibody? We have to check the anti-HBs titer. So it should be more than 100 international unit per ml. The schedule is 016 today, next month, after 6 months. So what will be the post-exposure prophylaxis? So that we have to be aware, especially health workers. Post-exposure prophylaxis usually percutaneous, needle prick injuries, ocular, with an infected patient, body fluid can contact with our eyes or mucous membrane. These are all post-exposure to the virus. So if we are exposed to a patient, HBsAg positive patient, suppose we are not vaccinated, we know the history that we are not vaccinated. So the post-exposure prophylaxis should be, we should receive a shot of immunoglobulin and the routine 3 doses of vaccine to prevent from the infection. Next is if we are previously vaccinated, we know that we have been previously vaccinated. but our antibody titer is if more than 10 international unit, our titer is more than 10, maybe we don't need any vaccination. But when we assess it, if it is less than 10, titer is less than 10, we should go for the same immunoglobulin and the course of vaccination 0.6. Okay, and this was regarding hepatitis B. The next, please. About the treatment ഒക്കെ ഒരുപാട് guidelines are they are reviving the guidelines. So what are the treatment goals? Treatment goals is to decrease the mortality by preventing the development of prevent the patient from the chronicity to the development of complication, and mainly goal, long-term goal, prevent hepatocellular carcinoma and liver cirrhosis. So we should be aiming HBsAg clearance and long-term undetectable HPV DNA. The short-term goal, HBsAg positive patients, normalization, short time ആയിട്ട് പെട്ടെന്ന് ചെയ്യുന്നത് liver inflammation കുറയ്ക്കുക, ALT level normal ആക്കുക, HPV DNA level and zero conversion, HBsAg negative. And patients with HBsAg negative hepatitis, treatment goals are normalization of ALT and then undetectable HPV DNA. Next. So, if therapy is not indicated in patient, patient will self-contain the infection after some period. So, the amount of rate of chronicity or changing to chronic infection is around 50 to 60%. So, only 10%, about 90% will be self-contained. So around a short percentage of patient goes to chronicity. So if somebody which is not needing treatment, so if patient, how will we assess or when the therapy is not indicated? Patients with HPV DNA more than 2000, if it is more than 2000, so every 3 to 6 months we should analyze the ALT level, and HPV DNA every 6 to 12 months, and assessment of liver fibrosis every year through scanning or fibroscan. Anything you should assess the fibrosis and also ALT levels every 3 months and HPV DNA every 6 to 12 months. It is the viral load is more than 2000. If DNA level is less than 2000, we should analyze the ALT level every 6 to 12 months and periodical HPV DNA and the liver fibrosis assessment for every 2 to 3 years. In the treatment, next please. Natural history. You can say that acute infection around 60 to 65%, subclinical disease about 100% recovery level. 20 to 20% acute hepatitis present 99% recovery. 1% only goes to fulminant hepatitis and it can cause mortality. 5 to 10% healthy carrier right above. It will not cause any complication. 4% only persistent infection and other than 10% chronic hepatitis found. Sometimes the persistent infection 67 to 90% goes to recovery. Like chronic hepatitis, 4% patients chronic hepatitis കുറച്ച് percentage ഉള്ളൂ cirrhosis or death hepatocellular carcinoma. So our aim is to prevent this patient going to mortality. Next please. About the treatment modalities, I am also not much expertise in this. Next please. Next please. Next. Several guidelines വെച്ചിട്ടാണ് ഇപ്പം ട്രീറ്റ്മെന്റ് പോകുന്നത് 2018 അതിൽ ഇത്ര അറിഞ്ഞാൽ മതി. കുറച്ച് ആന്റിവൈറൽ ഡ്രഗ്സ് ഉണ്ട്. ലൈഫ് ലോങ് ട്രീറ്റ്മെന്റിൽ പോവുകയാണെങ്കിൽ ഈ hepatocellular carcinoma cirrhosis decompensated liver disease we can prevent the patient from and cover 10 of our antivirals ആണ് ഇപ്പോൾ യൂസ് ചെയ്യുന്നത്. Next please. Okay, we can conclude with the hepatitis B. Next, please. Next. Next. So now we can go to hepatitis C virus. Hepatitis C is the largest hepatitis virus. It comes in the genus Hepacivirus. How is the transmission? Similar to hepatitis B, it has percutaneous. It's percutaneously transmitted usually by blood transfusion with IV drug use, hemodialysis, etc. And non-percutaneous transmission is also seen, but usually very inefficient. Sometimes sexual, perinatal, not much frequent like hepatitis B virus. So, okay, next. Next, we can see the natural cause. C, hepatitis C. C for chronicity in order. Mainly, hepatitis C is the virus more prone to chronicity. If acute infection occurs, 55 to 89% can go to chronic HCV infection. And this chronicity goes on for over decades and leads to cirrhosis. That 3% per year hepatic decompensation 1 to 4% hepatocellular carcinoma. Okay. And we can go to the acute phase of hepatitis C. Usually hepatitis C, when we get infected, usually asymptomatic. Usually, sometimes rarely symptoms occurs like non-specific symptoms. 7 to 29 days after the virus transmission, the HCV RNA is detectable in the serum. So HCV RNA will be high. So after around 4 to 12 weeks, the enzyme level increases. SGPT, AST, more than 10 times the upper limit. Serum bilirubin also increases in certain cases. But mostly the acute infection will be an asymptomatic case. So non-specific symptoms like fatigue, nausea, fever, abdominal pain, jaundice, etc. Sometimes in 50 to 84% patients will come. The main thing is that during transfusion and all, the blood transfusion screening വന്നത് പിന്നെ വളരെ rare ആണ്. Chronic hepatitis C is mainly around 80s and US അങ്ങനെ ഡെവലപ്പിംഗ് കൺട്രീസിലൊക്കെ വളരെയധികം റേറ്റ് കുറഞ്ഞിട്ടുണ്ട് ബ്ലഡ് ട്രാൻസ്ഫ്യൂഷൻ ടൈമിലെ സ്ക്രീനിങ് ഒക്കെ ഉള്ള. അതിന് മുമ്പ് ഇൻഫെക്റ്റഡ് ആയിട്ടുള്ളവരായി ഇപ്പം ക്രോണിസിറ്റിയിലൊക്കെ പോയി സെറോസിലൊക്കെ നമ്മുടെ ഇവിടെ കുറച്ചുകൂടെ ലേറ്റർ ആയിട്ടായിരിക്കും വന്നിട്ടുള്ളത്. സോ ക്രോണിക് ഹെപ്പറ്റൈറ്റിസ് സി usually the SGPT, ALT will be usually elevated again. Most patient goes in a silent state until the patient goes into the hepatic fibrosis or later hepatocellular carcinoma or other complication occurs. Till then the patient will be usually asymptomatic. And also the same thing like extrahepatic manifestation sometime occur. Next please. Extrahepatic manifestations are more pronounced in the HCV infection. There is a list of the autoimmune hepatitis, lymphoma, lichen planus. These are all proved and possible extrahepatic manifestations. Next, please. You can see the serology pattern. First HCV RNA, then ALT first raises, then anti-HCV. The antibody becomes appears in the body and it persists for life. How will we diagnose the hepatitis C? Mainly by serology. Anti-HCV that we are seeing in the graph. Anti-HCV may persist after the spontaneous recovery. Sometimes if the patient is spontaneously recovered, even after that, sometimes the anti-HCV will be persisting. Sometimes even after viral therapy. Regarding hepatitis C, the treatment is more proven and more effective. The antiviral treatment is nowadays more, no need of chronic use of drugs. It is resolved by the antiviral drugs more efficiently than hepatitis B. Hepatitis B maybe we need lifelong treatment, but hepatitis C can period 12 to 24 weeks then HCV RNA disappear. So sustained virological response means after the therapy is 12 to 24 weeks, if the RNA is not, we cannot detect the RNA, that is the response of the treatment. So even after this SVR also, sometimes anti-HCV will be persisting in the blood. After 5 to 20 years, it will clear from the body. The next is the HCV RNA that we have mentioned. HCV RNA in the serum we can detect by PCR. Sometimes if the patient is going to rapid progression or no progression or no response, or patient is going to chronicity. So for the assessment of liver injury, how much the liver been affected, we may sometimes need liver biopsy. Sometimes liver biopsy, and liver biopsy we are assessing the fibrosis, right? Scoring it and meta scoring 0 to 4. Fibroscan is now available. Sometimes replacing the liver biopsy. Nowadays, transient elastography or regarding the elasticity of liver, the grading ഉണ്ട്. അത് വെച്ചിട്ട് ഫൈബ്രോസിസ് എത്ര ആണെന്നത് അസസ് ചെയ്യാൻ പറ്റും. So, like we said, the natural history, the more chance of chronicity is in hepatitis C. So, what will be the factors that affect this chronicity? Sometimes എല്ലാവർക്കും chronicity ആവുന്നില്ല. Why the majority of patients? Sometimes age is a factor. This perinatally infected children, they may contain the infection, but if the infection occurs after some age, like more than 40 years, and males are more prone to be the gender that is going to have chronicity and complications. Raised ALT in the blood, alcohol consumption, other co-infections like HBV or HIV. These are factors sometimes lead the patient to chronicity and complication. So, yes. So regarding the treatment, home to treat. Significant fibrosis of the patients, decompensated cirrhosis, patient with clinically significant extrahepatic manifestation that we mentioned before, patients with HCV recurrence after even after liver transplantation, sometimes HCV recurrence are seen. Patients at risk of rapid evolution of liver disease because of concurrent with the comorbidities. These are patients, individuals at risk of transmitting HCV. That is risk of transmitting, that injected drug users, men who are sex with men. These are persons are at the risk, so they have to be treated. Next, please. Next, please. Nowadays, the antiviral drugs in the list, sofosbuvir, effective and 12 to 24 weeks treatment with the recover with the guidelines for it. Next, I'm also not expert in treatment. Now, next we can go to hepatitis D. D for dependent organ. It always depends on HBV virus. The B virus depend on. So it is called a delta hepatitis agent. The genus is delta virus. It is a defective actually RNA virus. It needs the help of HB virus always. So HDV antigen. It requires also always the HDV virus is contained in the HBsAg. So it is already dependent for infection also. It is already dependent on hepatitis B. This HDV, there is antigen called HDV, which is always encapsulated by the HBsAg. So 8 genotypes have been found out. So next, please. The infection. Regarding the infection, how the infection occurs, the two ways: co-infection and super-infection. Co-infection means simultaneously HDV infects a person with the HPV. HPV dependent on HPV co-infection gene. Next is super-infection. The HBsAg positive patient is infected with HDV. So how will it occur? The infection occurs from another HBsAg positive to an HBsAg positive. That is super-infection. So HDV version depends on HBV. So what the duration of the infection also, it is determined by the duration of HPV infection. So HDV antigen also we mentioned that it is contained within the HBsAg code source. Occasionally it is detectable in serum. and antibody to the HDV antigen occurs. This anti-HDV IgM class after 30 to 40 days after symptoms. IgM antibody occurs, and after the acute phase is after the acute phase, the IgM antibody will be disappeared and IgG occurs. So next please. Modes of transmission, same like percutaneous exposure, injecting drug use, mucosal exposure, sexual contact. Next please. Next please. Superinfection, co-infection serology, geographical distribution. So about the prevention. Prevention means like next please. Next. Okay, prevention. Usually, along with the hepatitis B vaccination we have mentioned, the prevention of the HDV also comes with that. And superinfection. Already he's a hepatitis B patient. So how should we prevent? Educate the patient to reduce the risk behaviors. That's the way to prevent the HDV infection. So no specific treatment exists for HDV as it is co-infected with HDV. And that's regarding HDV infection, hepatitis D. Next, we can go to hepatitis E virus. Next, please. Next, please. Hepatitis C. We all know that it is very much similar to hepatitis A virus. It is also enterically transmitted, and it is excreted through stools in the late incubation period. And the difference between what is the difference between A and E is that the interpersonal spread means person-to-person spread is lesser compared to HIV. So in the close contact spread, it's not much relevant in hepatitis C. Only thing that is careful with hepatitis C is the infection in pregnant ladies. It can cause to some serious hepatic failure or even mortality rate is high in pregnant ladies. Most of the outbreaks or a history and outbreaks ഉണ്ടായിട്ടുള്ളത്. Minimal person-to-person transmission. Next. So the prevention. Prevention means mainly it's said about the travelers and avoid drinking water, which is unknown purity, uncooked food, shellfish, uncooked fruits and vegetables, etc. Then ഇതൊരു എൻഡമിക് ആയിട്ട് നിൽക്കുന്നതായിട്ടാണ് പറയപ്പെടുന്നത്. ചില ഏരിയ മെഡിറ്ററേനിയ ഏരിയ ഇന്ത്യയിലൊക്കെ ഉണ്ടെന്ന് പറയുന്നത്. So it's also a self-limiting infection, not much serious like other parenterally transmitted infections. Also, only thing to remember is the infection of the pregnancy. Vaccine പറ്റി അറിയില്ല. Vaccine ഇതേവരെ endemic area not much aware of it. Okay. So briefly, ഞാനിപ്പോൾ ബ്രീഫായിട്ട് പറഞ്ഞു. ഇത്രയാണ് relevant ആയിട്ടുള്ള ഹെപ്പറ്റൈറ്റിസ് വൈറൽ ഹെപ്പറ്റൈറ്റിസിനെ പറ്റി ജസ്റ്റ് ഒരു മിനിമം നോളജ് വെച്ചിട്ട് ഞാൻ പറഞ്ഞത്. സോ ഐ തിങ്ക് വി ക്യാൻ കൺക്ലൂഡ് വിത്ത്
ഡൗട്ട്സ് എന്തെങ്കിലും ഉണ്ടെങ്കിൽ ചോദിക്കുക കേട്ടോ ഡോക്ടറുടെ ഈ സമയത്ത്. ഡൗട്ടൊന്നും ഇല്ല തോന്നുന്നു.
അല്ല, മോഡേൺ ആസ്പെക്ട് മാത്രമാണ് പറഞ്ഞെന്ന് തോന്നുന്നു. അപ്പൊ അങ്ങനെ ഒരു കാണുമായിരിക്കും. നമുക്ക് അങ്ങനെ ചില സംശയങ്ങൾ ഉണ്ടാകാം ചിലപ്പോൾ അല്ലേ. എന്തായാലും സബ്ജക്ട് വൈസ് നന്നായിരുന്നു ഡോക്ടർ പ്രസന്റേഷൻ. അപ്പൊ താങ്ക് യു വെരി മച്ച്.
താങ്ക് യു സോ മച്ച്.
ക്ലാസ് ഇത്രയും നേരം അറ്റൻഡ് ചെയ്ത ബാക്കിയുള്ള എല്ലാ ഡോക്ടർമാർക്കും നമസ്കാരം.